Thank you. It really is an honor to be here and to be invited to come to this organization and also to be with this group of elite researchers. I was brought up to be polite, mind my own business. A great virtue, as far as my parents were concerned, was not to be nosy. That kind of upbringing is enough to lead anyone to a career in which you spend your life asking questions. So here I am. I'm very pleased to be here today. And that really is my role, is I have, as in my job, I try to be a surrogate for my readers and figure out what it is that people want to know and what they need to know, what they should know. And so with that spirit in mind, I have come up with a list of questions that I will put to these researchers, and we'll see if we hit the targets that you want to know, and if not, there will be a question and answer period at the end. All of the people on the panel have given me their informed consent, and I will be performing surgery on their remarks. If they're all prepared for me to jump in and ask them to clarify or to slow down or to speed up if we need to keep things moving. So they're all prepared for this. So with that, let me go right to the questions. And what I think most people here know is that we have something like 230,000 new cases of invasive breast cancer every year, and plus another 58,000 or so of the in situ kind of stage 0 cancers. So what I'd like to start by asking this group is there any prospect for prevention? And when I ask that, I'd say, is there any percentage of that number, that 230,000 cases, that we would have some hope of preventing now with means that are already available? And I'm not just talking about the extreme kind of prophylactic surgery that women have when they know that they've got a very high risk. Now, I will direct some of these questions to people on the panel who I think will have something to say about it, but I think the others who want to speak about it will jump in. So I'd like to start with Dr. Davidson on this question of risk and prevention.
So the simple answer, Denise, is yes. You know, this is an area where we have actually had an amazing, over a decade, of clinical trials that have looked at ways for us to try to identify women at high risk and then to use pharmacologic, to use drug interventions to try to decrease their risk of developing invasive breast cancer. In breast cancer, we have 2 FDA-approved drugs that are able to be used in this situation: the drug tamoxifen, which is an anti-estrogen, and the drug raloxifene, or Avista, which many of you know because it's also a bone-strengthening agent. So I think actually one of the big failures for us as a profession is that we haven't really capitalized on this enormous body of both preclinical science and clinical trial information and availability of these drugs, which are very well tolerated, as a means of going out and using them in the population to try to reduce the diagnosis of breast cancer. Just over this last year in the news, and Denise, I think you helped publicize it as well, a third drug, one of the aromatase inhibitors, exemestane, was also found to decrease breast cancer risk. And each time we're talking about reducing risk by about 50% in high-risk women.
How do we know who needs those drugs?
Well, I think that's one of the huge things, is that we need to do that as doctors, and we need to do this as women. There are very well worked out algorithms. You can go online and look for the National Cancer Institute tool that helps you define breast cancer risk. Very simple, takes about a moment: your age, your family history, whether or not you've had breast biopsies, a couple reproductive things. Very straightforward. The FDA label for these drugs is anybody whose risk of developing an invasive breast cancer, according to this algorithm. Anybody whose risk is over 1.7% over the next 5 years would be a candidate for these drugs. So the cardiologists have done it. They help us to think about cardiac risk. They talk to you about your blood pressure. They talk to you about your cholesterol. And they help you manage that to try to decrease your cardiac risk. And we haven't done that well in breast cancer, in my opinion.
Let me ask you another question about that, and this is just from the patient point of view. And I'm using myself just as an example. I think I'm fairly typical. So I have gone into that website, put my numbers into that risk calculator that you can play around with. And the questions it asks are, when did you have your children? Have you had biopsies? How old are you? That kind of thing. My numbers come up higher than the average. They come up higher than that 1.7%. It doesn't seem all that high to me, but it is higher than the average. So then my question is, well, gee, if I thought I wanted to take one of these drugs or I wanted more information about this, as an ordinary person out there, who do I go to? I think my internist is not up on this. I think my gynecologist does not really have time for this either. So who do I go to? I don't think I need a genetic counselor. I don't think I need an oncologist. I don't have breast cancer. So if we should be doing this and doing more of this, who does it fall on?
So let me try and answer that question. I think that one of the problems we've had with breast cancer prevention is we really haven't approached it in a systematic way, particularly the way they did to develop the tools we have for heart disease, which came out of the Framingham study. We've started something across the University of California medical schools called the Athena Breast Health Network, and Barbara Parker is here and participating in Hope Rugo and that. And what we've decided to do is really approach this in a much more comprehensive way and create the infrastructure that is needed to get the people to help understand that. We are creating a group of women who are trained called breast health specialists. Actually, Patty Gans is also involved in this. And so what we would say is that there are a number of things that you should do. At the time of screening, mammography is only one of the tools that you should be using, but comprehensive risk assessment should be part of what everyone does. And that is something looking at your lifestyle, whether you're taking postmenopausal hormone replacement, what your body mass index is, how much alcohol you're drinking, whether you happen to be from a family with strong family risk. And you actually need a number of different models, not just one. And you actually need a cadre of people who are trained to help answer these questions. And we have to begin the education of those people. And we are actually doing it through our genetic counselors to begin with, and creating this breast health specialist and working with the internists. And we've also created a tool called breasthealthdecisions.org that helps go through these issues with women. So someone like you, who has a little bit of elevation in their Gale risk, but not huge, if you happen to have low bone density, the perfect drug for you might be raloxifene. But if in fact you happen to be someone who drank a lot of alcohol or your body weight was high, there's a lot of things that you can try and do. And it is a comprehensive approach to try and thinking about what are the things that we can do to drop that risk. It's estimated that probably a third of breast cancer can be prevented with this approach.
So a third, so we're talking 70, 80,000 cases a year?
Yeah,
That's huge.
Warren Chablowski often likes to say with the publication of the Women's Health Initiative that he's prevented about 100,000 breast cancer cases in the last 5 years or so by getting people to stop combined hormone replacement
I see
therapy.
Dr. Sledge wants to make a comment here too.
Yeah, getting back to Nancy Davidson's point, the problem that we face in this country is pretty simple. Lipitor is prescribed by general internist, family practitioners, and general gynecologists. Tamoxifen is not. Both of those drugs have a virtually identical reduction in terms of the number of lives saved for the use of the prescription. But in this country, we have not trained the people who are most likely and who should be prescribing the drugs to prescribe them.
Let me just jump in here. I just want to clarify something you said. You said they both have this savings, life savings, with tamoxifen. And when you're talking about that from tamoxifen, you're talking about people at risk, not women who already have cancer and are being treated.
That's correct.
People at risk, healthy people, but at elevated risk.
If you look at the number is about 1 in 300 is the reduction in terms of breast cancer rate overall. And that's identical reduction to what one sees with the risk of heart attacks with Lipitor. I mean, it's very similar, but we don't train in this country internists, family practitioners, gynecologists to prescribe these drugs.